My name is Christopher Holland, and I'm a complex and minimally invasive spine surgeon with Carolina Neurosurgery and Spine Associates in Charlotte, North Carolina. I'm here today to present a case review of a patient who underwent a 2-level minimally invasive transforaminal lumbar interbody fusion. This patient was a 69-year-old female with a BMI of 34.7. She had a 2-year history of chronic low back pain with radiation into the left greater than right lower extremity. She had significant progression of her symptoms over the past 6 to 8 months, with a significant limitation of her overall quality of life, as well as her ability to participate in normal activities of daily living. She was experiencing claudication in both legs with walking even short distances, and was dragging and catching her left foot and toes. She underwent physical therapy, dry needling, multiple transforaminal epidural steroid injections, facet joint injections, radiofrequency ablations, and pain management without any durable or lasting improvement of her symptoms. The patient was found to have a multi-level spondylolisthesis at L4, L5, and L5S1. There was up to 10 millimeters of anterolisthesis and 4 millimeters of dynamic instability at the L4, L5 segment. At L5S1, there was up to 8 millimeters of anterolisthesis with 1 to 2 millimeters of dynamic instability between flexion and extension. On physical examination, the patient was in moderate to severe distress with a grossly antalgic gait and a mild left limp. She had a pain-limited left lower extremity examination with 4+/5 strength in the left iliopsoas, but otherwise 5/5 strength on exam. Her examination otherwise was normal with normal sensation and reflexes. On her radiographic imaging, lumbar AP, lateral and flexion extension x-rays were obtained. This did again demonstrate multi-level spondylolisthesis with dynamic instability at both the L4, L5, and L5S1 segments. Her MRI of the lumbar spine demonstrated severe central and severe lateral recess stenosis at the L4, L5 segment with displacement and likely compression of the traversing bilateral L5 nerve roots. In addition, at the L5S1 level, there was mild central stenosis but with moderate lateral recess stenosis, again with encroachment on the traversing bilateral S1 nerve roots at this level. There was no significant neuroforaminal stenosis. Here are some examples of her preoperative imaging showing the degenerative disease at the L4, L5, and L5S1 segment with the severe central stenosis at L4, L5 centrally. On the dynamic radiographs to the right, we see flexion and extension views showing the spondylolisthesis at L4, L5 with significant dynamic motion between flexion and extension views. The patient underwent a 2-level minimally invasive transforaminal lumbar interbody fusion from a left-sided approach. The patient had predominant left lower extremity radiculopathy, and as such, the left-sided approach was preferred for direct decompression of the lateral recess traversing and exiting nerve roots at this level. Expandable interbody cages were placed at the L4, L5, and L5S1 segments and expanded until tension was felt on the expansion driver. Intraoperative fluoroscopic images confirmed pedicle screw and interbody cage placement. Reduction was achieved using rod placement and set screws in order to reduce the spondylolisthesis at both segments. Postoperative images here obtained in the office and follow-up show stable pedicle screw rod instrumentation with interbody cage placement. There is no evidence of hardware failure or complication, and there appears to be good early bone formation within the interbody space, as well as posterolaterally on the right side, where there had been extensive decortication and bone graft placement at the conclusion of the procedure. The patient did quite well and was able to return to work as well as all of her normal activities within the 6 to 8 week period following surgical intervention. This patient's surgical intervention was quite successful. She mobilized early and was able to be discharged from the hospital after 1 night to home without any supportive services. She quickly weaned from narcotic pain medications and returned to all of her normal activities without restriction. She was thrilled with her surgical outcome.